Thanks very much, Esther. So it's a pleasure to be here today. As Esther said, my name is G.J Melendez-Torres, and I'm an epidemiologist at the University of Exeter. I'm also Associate Dean for Researcher Inclusion of the NIHR Academy. And my brief today is to talk a little bit less about my work with the Academy and more around my perspective as a researcher delivering NIHR-funded research and how sex and gender is relevant for that in particular. Now, even though I believe sex and gender is relevant for all applied health research and all research more generally, I particularly work in areas where sex and gender are inescapable. The majority of my NIHR-funded research focuses on child and adolescent mental health, as well as on the prevention and treatment of intimate partner violence and gender-based violence as well. So sex and gender clearly is central to the work that I do, and I'm really pleased to have the chance to talk a little bit about how this perspective informs the work I do on NIHR-funded research. On NIHR-funded research. So the subtitle of my presentation is around creating evidence that works for everyone. And when I think about evidence that works for everyone, I'm particularly inspired by this work from Witt and colleagues. And I actually believe one of the co-authors of this piece is presenting to us later today, Dr. Kate Walmsley. And when we think around evidence that works for everyone, that requires understanding that accounting for the ways that the epidemiology that we study or the interventions and programs that we evaluate have differential impacts or have differential patterns over different population groups isn't just a niche, it's actually core to the work that we do. And that's important as well because it means that we need to create evidence that works for everyone. When I talk about evidence that works for everyone, what I specifically mean is evidence that meets the needs of our entire population, not just some hypothetical average person, and that accounts for those perspectives in the design and delivery of that research. Now, as a researcher, when I think about research for everyone, I think around three things. I think around the first point, which is that I want to deliver research that begins with an accurate understanding of the problem. And sex and gender is an often neglected part of that. I also want to deliver research that is relevant to everyone, and that requires accounting for sex and gender. And I also want to deliver research that is innovative. And taking a sex and gender lens to that research can often generate innovative ideas that will help to break the gridlock around some of the really intractable health problems that we see in NIHR-funded research, but also across the world of population health more generally. Now, when I think around research that draws on an accurate understanding of the problem, as I said, I think around some of the work I do where sex and gender isn't just relevant, it's inescapable. And in particular, some of my work on intimate partner violence has really brought me into contact with people who, quite frankly, disagree that we need a gendered lens to understand this. Back in 2021, in fact, in the week of International Women's Day, I was presenting the results of an evaluation that my team led to understand how health systems in the NHS, how trusts rather, in the NHS respond to women victim survivors of intimate partner violence, and how that whole health response can be optimized to ensure that victim survivors, specifically women victim survivors, are appropriately supported over the course of their journeys. Now, at the beginning of that presentation, which my colleagues at Standing Together Against Domestic Abuse were live tweeting, I began with what I thought were some fairly uncontroversial points, specifically the idea that we can't understand intimate partner violence without a gendered lens, number one, and number two, that we need to acknowledge that some women disproportionately experience the impacts of gender-based violence and intimate partner violence more specifically compared to other groups. So this webinar, which was done because, of course, we were still in peak COVID, generated some really interesting feedback online. And I often describe this as the first time that I was called a misandrist on social media for being really clear around the importance of a sex and gender perspective on intimate partner violence. Now, this pales in comparison to some of the abuse that many of my women colleagues experience on social media for doing work that takes a sex and gender lens. But it reminds me of the ethical imperative to ensure that our accurate understanding of the problems that we're trying to address through applied health research begins with a really specific and really rigorous sex and gender lens as well. Louise Howard and colleagues wrote in 2017 around the importance of an accurate understanding of the problem, including sex and gender with respect to mental health. And a lot of what they wrote back then is still really relevant today. In particular, the need to understand how it is that sex and gender shapes our understanding of the epidemiology of mental health conditions as well. We know now, of course, that the epidemiology of mental health is highly gendered, but that doesn't mean that mental health epidemiology as a field has really responded to that call. One of the things I'm really hopeful for as a social epidemiologist is that we will continue to respond to that call and will respond to it more clearly as we seek to develop better understanding of how public mental health can be improved and optimized in the UK and around the world today. Another example of this relates to some work that the Exeter Policy Review Program facility, which is NIHR funded and which I help lead, undertook to support the women's health strategy. And the particular focus of that work was on understanding how it is that GPs communicate with patients with gynecological conditions. One of the reasons why we believe this was particularly important was that we understood from early stage stakeholder involvement that a crux of delivering on an effective women's health strategy would be improving the way that primary care clinicians communicate with women about their health as well. So we undertook this review with a specific and specifically developed sex and gender lens in order to really get underneath the crux of the problem, which is that oftentimes, far too often, when women present to primary care with gynecological conditions, their symptoms, experiences are not being respected. I also want to flag that when we think around research relevant to everyone, this is an ethical question as well. Laurentian and Oliver talk around how research can generate equity arms, specifically when the actions we take exacerbate these unavoidable, unnecessary, and unjust health differences between groups. Ensuring that research is relevant to everyone means ensuring that where benefits are evident, those benefits improve or at least do not worsen inequities. We have quite a lot of room to really understand the relevance of a sex and gender lens as an ethical imperative, to pick up on Gail's point, with respect to the NIHR-funded research that we do. Drawing from elsewhere in the NIHR universe, Aston Chamberlain and colleagues looked at NIHR-funded trials in emergency care. And what was found in Aston Chamberlain and colleagues' review is that disproportionate enrollment of women, even beyond differences in baseline prevalence of the condition being studied. Very few trials, if any, included a sex disaggregated analysis in their reporting, and in fact, many trials included sex-specific exclusion criteria, which again limits the relevance of that research to everyone, everywhere. And in another area that is very relevant to NIHR's work, Hall and colleagues looked at 128 trials of systemic anti-cancer therapies receiving FDA approval. Often in these trials of systemic anti-cancer therapies, the primary outcomes relate to overall survival as well as progression-free survival. Those two outcomes are obviously critical to ensuring the health and well-being of people who are receiving these treatments. But we also know that the impact of adverse effects of these therapies is substantial and often sustained. And we also know that those side effects, those adverse effects, are not distributed in the same way over sex. And so one of the things that I think was really telling around Hall and colleagues' review was their finding that absolutely none of the trials that were reviewed presented toxicity data disaggregated by sex or gender. This suggests that we're missing quite a lot of the picture that would support treatment decision-making for women as they undertake decisions around systemic anti-cancer therapies as well. And finally, research that is innovative. What are the possibilities that a sex and gender lens creates for action on population health? One of the areas of my work is on the intersection of child and adolescent mental health and gender-based violence, which is specifically the prevention of gender-based violence in schools. And one of the real transformative developments in that field over the last several years has been incorporating a sex and gender lens very specifically to understand the possibilities of a gender transformative approach. Percival and colleagues talk about a gender transformative approach as one that seeks to diagnose, to address, and then to improve unequal gender norms, including the ways in which those gender norms disproportionately impact different groups. So when I think around one of the real innovations that a sex and gender lens can offer to us from a population health perspective, I think particularly of the impact that a gender transformative approach has had on the ways that we support children and adolescents to grow up and become healthy adults. So moving forward, acknowledging sex and gender creates possibility. It creates a possibility of research that begins with a clear, more complete account of the problem, a research that doesn't just not worsen equity, but that in fact can improve equity and is relevant for everyone, and a research that is innovative, seeking deeper solutions to challenging problems. So I thank you very much for your time, and I'm looking forward to hearing what my colleagues have to share in the coming presentations.
Thank you, GJ, for that talk. It's always good to hear the researcher perspective, but also interesting to hear all the work that you have done in this space.